Welcome to KIMEcast, where we break through and cut the BS in sports medicine, rehabilitation, and sports performance, and talk about how things really work. Hey, welcome to KIMEcast. Tony Mikla, Russ Dunning. So it's been a great week, man. This last week we finished up one of our scholarship awards, which was really great. We had an amazing number of applicants. We had this huge pool of applicants. Then we narrowed them down to top 10 to top 4, and it was really cool. On Friday, we got to interview the top 4, and this is it's really, really strong. Like it's really strong, like personalities where people are like really wanting to make an impact. I was really impressed with the group as a whole. It's pretty.
What were the guts that you looked at?
So we wanted to, obviously we're looking for somebody who's like interested in sports med, and they want to make an impact in that field. So we asked them to write an essay. We asked them to submit their resume, a couple letters of recommendation, and then the finalists would be interviewed. And when we were interviewing, we were looking for the same criteria that we look for our team. You know, how are their ability to communicate? What's their passion for the field? And then did they have some sort of direction that they saw themselves going in to really like make an impact? Did they see a pathway? And I think a lot of times we'll talk to a student, especially in their first year. A couple of these were first year, so especially in their first year, and they won't have that pathway at all. It'd be very gray, like open to different things and all that stuff. But this entire group was, as expected, was very much like, this is what we're doing, which was great to see. So that was super cool. And they were all kind of unique in their own way, as people are, but unique in their own way, the way they approach things. Some guys just really, really high on passion, a little bit less direction. Other ones like maybe less passion, like showing, but very, very directed. And then through that, you could see the passion and impact. But almost all of them had a pretty clear path. Like afterwards, is really what I intend to do, what I intend to get involved with, how I tend to move the needle a little bit, which was good. It was obviously to be expected. That was hard for them to like clearly identify and express, but you could definitely see that it's there. Like the thoughts were there, you know? So it was really good. It was a good group. It was really cool. So what we decided to do is, because we had such a strong group, this is actually your idea, so I'm just reciting it for everyone else. But what we decided to do was, because we had a strong group, is to have a winner that gets a $2,500 scholarship to go towards their school and education to finish out their time, and that's awesome. But because we had such a strong showing too, we wanted to go ahead and award some of the other finalists as well. So we're going to do that at a smaller amount of $500 for some of the other finalists as well. So I think it'll be a great step forward for them, and just recognizing what they're doing and the commitment they're having to the future of the field is pretty bright. So it's pretty cool.
In the scholarship realm, are there other groups that are doing this, or any other entities did you find?
You know, I haven't seen much of it. I haven't seen much in this space. I think there's some things out there on like early commitment. You know, like if you were to say, hey, I'm going to go to PT school and this is my plan to work for X company in the future, then I think there's some opportunities out there where you can get some funds from that particular entity to help pay for school. And I think that's pretty variable, and it's a little bit different, because usually it's hard for a student and a employer to kind of match up prior to going to school. But I think that this alignment of trying to find the best students, the best and the brightest, the top 5% of the students, to really that's what applied for the scholarship, was the top 5%. These are definitely people that would be all in our pathway of like what we're interested in, what we're passionate about, and would be great employees and great team members for us. So when doing that, we found that we had a great return. So it was really valuable.
I love the energy on this. When I think we look at our entire industry, having high curiosity matched with high passion for a person to do the kind of work that we do, I think is so essential. And then where does that start? Yeah, it starts, usually in college, when people kind of get a little bit, hey, I think this might be a great pulse. And to kind of feed that fire for someone who's 19, 20, 23, 25, like really young, and maybe their career maybe can go in a lot of different ways, but to fuel that fire feels like such the right thing to do.
Yeah. It is. It's a big deal. I mean, I had that. Like, I had some great mentors, even like when I was an aide, and when I was in college, I just worked at the Student Health Center as an aide, and the lady's name was Mary Hallbeck. Mary was, I just saw her a couple weeks ago when I was back down at school. And she was awesome. She encouraged me to get my CSCS, and she's like, hey, I'm going to get it as well. So I'll pay for all the study materials if you just want to take the test and sign up, and we'll study together. And so we did. So I got it as an undergrad, which was huge. She really encouraged me to get into the weight room and work with the coaches and work with some strength coaches and learn like the Olympic lifts at a different level. I was already doing that with sports, but that kind of just certainly added like a degree of like going and meeting with some other ones outside of the main sports group. So that was fantastic. She recommended to me highly at the time. She's like, whatever you do, go to the cheapest PT school possible, because it's not worth, you're not going to get paid more because you got a better degree from an expensive school, which at the time I kind of laughed at, I was like, man, that's interesting advice. She's like, well, it's just true, and you really can't understand it until you get into it. And it's very much accurate. I mean, I think now there's a huge push towards leaving school with the minimum amount of debt possible. Mm-hmm. But that was just an off the cuff recommendation she made for me at that time. So I think mentoring people as they're going, that was an undergrad. So before they go into grad school, can be tremendously valuable. Yeah.
When I was going into PT school, I had no thought of what's the best school. My brain didn't think like that. So I studied biomedical engineering. Well, I say mechanical engineering, then biomedical engineering. And what's kind of fun about an engineering life is that principles are principles regardless of where you learn them from. Like textbook's still a textbook, applying that, So I think there is the MITs, and the Stanfords of the world, but really I don't think people go to elite universities to learn from the best professors. I think they go there to be surrounded by the best. So I think it's much more about what's your network, what's your peer group, what's the cohort look like, rather than the best teacher. And in that realm, like I didn't think much of it, of what's the best school. Like just give me the material and I'll absorb the material at a high level. That's what I'm used to doing. Yeah. It didn't matter who my professor was. The material was the material. I was going to mow it down. Yeah. So, but what I can really appreciate though is what is your cohort? And if you've never been part of a good team, this goes back to our team mindset of what great teams have you been a part of? And maybe it's a great classroom, maybe it's a great study group, maybe it's a great grad group. Yeah. Or it is, actually a sports team. Or I think teaching excellence is the main part about a team. And if you need to learn what that looks like academically, then so be it.
That's a great point. I like that. I think it's so true. I mean, we see that academically, that I think the cohort's a big, big deal. I do think in PT school, when you're choosing schools, I don't think the school makes all that much of a difference. But if there's a certain number of professors at that school that have a certain research bias, and that's pretty high on your interest list, then I think that could be a school to at least look into and look at and make sure that it fits the right needs. I think that networking is really, really important. I think that's a great way to start building a network. Because if you've got a professor at a school that's very well networked with other sports researchers and such around the country, around the world, and that's an area that you want to be involved with, there's people that you want those contacts and want to be a part of that group, then I think that's super valuable. But as far as the network goes for your job, it plays a role, but you'll evolve that no matter where you're at. Mm-hmm. Obviously, going to UOP, my network originally was very, very strong UOP people. Mm-hmm. First job was to another UOP grad, and some of my internships were to other UOP grads. So it was pretty tight on that to some degree. Mm-hmm. So that was clearly pretty easy to leverage. And I think that's true with other things. We had Ian Book on here, and I was talking with Ian back when he was in high school, and I was like, man, you go to Notre Dame. I said, you can always, you'll always find work afterwards, regardless of what happens, because Notre Dame is a really, really strong, tie. Like if any alumni that went to Notre Dame and you say you went to Notre Dame, they're going to know who you were, first of all, but you're going to get that interview. You're going to get a shot. Yeah. Because it's just, it's that kind of a group, and, USC is like that. A lot of these groups, all the Ivy Leagues like that. Yeah. I think most schools are like that to some degree. So that is valuable for sure. Mm-hmm. Where I think getting into an environment where you have a network you can lean into, that you can leverage in some way, is a tremendous asset. Mm-hmm. So one of my buddies hit me up with a text just last night. He's like, "Hey, what do you think about this?" So in the APTA, they are talking more about the specialty cares, right? So if you're not familiar with this in PT, there's 9 different specialties. So sports is one of them, orthopedics is one of them, aquatics is one of them, pediatrics is one of them, geriatrics is one, there's neuro, and then there's I think there's probably a wound and probably a cardiovascular. So there's like these different specialties within the PT industry. And if you go to school, you graduate, and then you can basically prepare to take one of these specialty exams, which is like you have to put in so many hours. They require you have to have a mentor. You have to go through like a fellowship or residency. Typically, is usually recommended. You don't have to, but it's recommended. And then that residency prepares you for taking this exam. Then you take this didactic exam, and then you get awarded this specialty. And then the specialty usually lasts for like 10 years. And then you have to like re-certify, basically take the test again. And you pay a ton of money to do it in the first place. It's usually several $1,000s to kind of get in and do it, and you get this recognition. But the big argument is that recognition is correlated to no increase in pay and really no better job than you would have got otherwise. That's a little bit debatable. There are some places that certainly recognize the specialties and say, that's not necessarily paid more, but it's required to get in. Like for the military, for example, they required an OCS as part of the deal if you wanted to work with the special forces and some of the groups we were working with at the time. That was one of the requirements they had for their employees. But nonetheless, he reached out to me with the focus on there's currently a proposal to add a new specialty group, and the new specialty group is private practice. What's the word? Like general physician.
Primary care.
Primary care. Thank you. Not private practice, but primary care. So the new specialty suggestion is that there's be a new primary care specialty. And it's kind of interesting. So I was looking through it a little bit. So this thing is 389 pages if you want some light reading.
Wow. Okay.
On what all this thing goes into. But the idea is identified primary care as physical therapists working in primary care as part of the differential diagnosis and kind of filtration process. So interesting. I think it's great for PT to be considered in this way, first of all. Whether or not it's a specialty, I think is a separate conversation. But for now, I think the idea of PTs, and this is great. And once again, back to the military, we've seen this in the military that they've used PT heavily as their musculoskeletal screening. And if you think about it, it makes perfect sense. The majority of their people are, between the ages of 18 and 22 years old, 24 years old, something in that zone. So most of the issues they're going to have are going to be musculoskeletal. They're not going to have a whole lot of other things that weren't already screened with their original physical or their annual physicals, et cetera. So most of the problems are going to be musculoskeletal in nature. So what they typically, my understanding is they typically use PTs as those primary care filters because usually it's going to be plantar fascia, anterior knee pain, IT band syndromes, back pain, different types of foot pain, maybe a shoulder issue. And so they go to PT first, then PT filters it out and then decides like, okay, do you need to get an x-ray? Do you need to see the doc? And they're making primary care level decisions. Do we need to send this out to a doctor? Do we need to get an image? Should we consider an injection or some other type of treatment? In a lot of military cases, my understanding is they actually do provide the injections under physician orders. They can order x-ray, and they can obviously refer out or send a script to a specialist. But I think it's a really great model in that environment for sure, because the odds of being a musculoskeletal case are huge. And I think we're quite good at musculoskeletal.
Yeah, I was going to do a little search on how many primary care physicians versus how many physical therapists. I mean, we got 380 million people in the United States. To properly filter that many people, I think we can all agree that many people feel like we're jammed up in the system. However the system is made.
There's definitely a shortage.
You're like, oh, I can't see my doctor for 3.5 weeks, and I need to see someone now. But for a reason, someone can say, can I see Russ tomorrow? Like, well, sure, I can see you tomorrow. So it seems like a lot of PTs kind of have bandwidth to see people quite rapidly. But everyone's shoveling through the doctor, and it's a tough funnel.
Yeah, when there's no doubt a huge problem there. It's a huge bottleneck on people seeing the doc, which is why you see them filling up the ER, which is driving up the cost of healthcare, because now you have people going to the ERs for just medication refills and basic questionnaires because they can't get in to see their doc. So I think that's a big deal. I think it's a good thing. I think that we have a skill set because we see so much musculoskeletal condition. And most people know when they have an issue, they're like, oh, this is musculoskeletal. And at that point, I think they could have a potential selection where hey, I'm going to go see my PT, which we already have. We already have direct access. This is already possible. So they could say, hey, I think I have a musculoskeletal problem. Go see my PT. And the PT's job is to evaluate the condition and say, yeah, this is musculoskeletal. This is likely soft tissue, or it's a bone, or it's a joint, or whatever it is. So this is the treatment plan we would do for it, and let's execute. And in most states, they're allowed to do that to a certain degree. Like here in California, we're allowed to do that for 12 visits or up to 45 days. So in those 45 days of working with the person, or 12 visits, whichever comes first, if the person is not better and they need to continue care, then you would have to get a referral from the doctor. You have to send them back to the doc. The doc would say, yeah, keep going. That's the right diagnosis. It's not, you haven't missed anything. So I think that's already covered with direct access as far as that goes. But I think we're quite good at that, where we could easily say, hey, this person comes in, we evaluate them, and like, you know what, this is not musculoskeletal. This actually is an internal organ referral pain that you're feeling. And we need to get this checked out. Let's go get you to your GP so we can guide you better to your next wave.
Yeah. I am trying to think of, the boom of intelligence and the boom of technology, and, who's going to own the world in 10 years. There'll probably be about, 7 or 8 companies that probably will own the whole world. And what would they do to try and manage, millions of people? And, right now I think tech is getting pretty good at saying, show me movement. I think if you were to redesign healthcare from, ground one, what's the complaint? And if the pain pattern is anywhere in your thorax, well, then you should probably ask, infection questions, maybe get a blood test. And then if you can rule out, big stuff, then you go right to PT. You go right to us, and we look at movement and help you with movement. And it seems like it's a pretty easy differential. If you had a blood test and a few questions, you can rule out a lot of things.
Yeah. I don't think there'll be 7 companies that rule the world, just to be clear, but I do think they would have a high influence.
They'll run all of the intelligence of the world.
Yeah, I do think to some degree they'll have a lot of rule, but I think there's a lot of little infrastructure things that the other things need to happen. Like, for example, like waste management, that needs to be a thing. Like,
but the data of waste management will be owned.
Absolutely. Will be owned and controlled.
Who will be the intelligence behind everything?
Yeah, well, we've talked about it many times. I do think that those the big tech groups will be there. And I think what's happening in that front, which they're moving to this model, so it's certainly a good alignment where they're moving to, like, Amazon bought One Medical, and you see now that Amazon's offering, pharmacy. So now you have Amazon offering food, Amazon Fresh. You have them all the products their whole marketplace, and then now they have pharmacy, and they have pharmacy in I think all 50 states or in most of them, that's important. That means that they have a doctor in all 50 states, because you can't prescribe outside of your license of your state. So they have at least 50 docs, if not hundreds of them, in each state, prescribing medications based on, if you're an Amazon member and you get a prescription for an Amazon pharmacy, a prescription for a drug, the pharmacy can serve you, but it has to be local from the state you're in. So that's kind of a big undertaking and like a big deal to get through like the legalities of that state to state. So nonetheless, they've done that. And the next step simply is to kind of continue to accelerate what you're seeing already, is you're seeing these remote doctors, like, HIMS would be an example, or HERS is another thing, or like Get Roman's another one. These remote doctor systems where, you call in, and you get, I have not done it, so I don't know, but you call in and you get you got a doctor on the phone, you do a little consultation, you fill out a small form.
Yes, quick questionnaire.
Typically been very specific to like certain things, like low testosterone or hormone management or hair loss, or really big things. But it's expanding, like the targets of this is expanding, right?
Well, my wife's doing Function Health, owned by Mark Hyman.
Okay.
And it's $500. You get 2 blood tests a year. They do 100 biomarkers. Every test you could think of, they do it. I think it's like 6 vials, and so it's a lot of blood you have to give, and you learn, quite literally every kind of test you could off of blood. For an extra amount, you can do cancer screening, and mind you, this is all like a clean upfront cost, no insurance, $500.
Yeah,
this is a person who cares about their health. Says, here's some money, I want to plan for the future, and I want to be proactive.
Yeah, I think that Amazon's taking the first leap here as far as these tech companies doing it, and I think you're going to see it. They've been talking about it for years, but I think you could see this in Walmart, you could see this in Apple, you could see this in these other groups. Oracle example, they could certainly go out and buy this healthcare branch, and I think they're going to look to do something like that, like a membership type program, right? Where you join as a member and then all of your basic healthcare can be covered that way. Yeah. Anything that's really like not life threatening, which would be us, which would be like PT would fall into that.
Yes.
You know, basic pharmacy would fall into that. Yeah. All the labs, as you spoke to, would fall into that. Certainly your GP, maybe they're doing this now with like behavioral health and like psychology and stuff. Same thing.
Relatively, we're the cheapest arm of the entire health industry, and we're the most potent at actually moving the needle later on. Talk about bang for your investment. We are the best investment that healthcare dollars should be. And I think as people realize that, they realize that the people that help others move better, you have a better long term. And then, you know, what do I do as a physical therapist? I think if anyone's listening that is a PT, I have learned how to speak triglycerides better. I have learned how to speak glucose better. I have learned how to speak electrolytes and vitamin D better. And it's because I've taken an interest in my own health, because I'm in my mid-40s. Tomorrow I'm turning 44. And I've taken a great interest in everyone else's health, because they always ask me the same question: how do I heal faster? And I had to think through that. How would I do it? I'd have these supplements, these vitamins, this amount of sunlight, this amount of aerobic activity, and I would get to work. And so I think we should get really comfortable with blood tests. I think for most PTs to challenge their thought process on more primary care medicine, to one, respect your primary care doctor. Respect the degree of information that doctor holds is vast and has an incredible range. Now, each primary care doctor might have their own like little subset of the things that they're, you know, particularly interested in, whether it's, you know, mental health or cardiology, or they're really good on the wound front. You know, whatever it is, they all kind of have their own little like flavor. We clearly have a flavor toward, you know, performance in sports. You know, I probably know more than about creatine than other doctors, because I've taken it myself, and I tend to want to learn about what creatine monohydrate does.
And you get asked about it all the time by your patients. I think that, I mean, if you think about it, like the spectrum at which the GP has to know here, like when you bring in mental health as a variable, I mean, that is like a massive category, right? And usually they're the one working through that, because there's not a whole lot of specialty recommendations. They're usually managing that with pharmaceuticals, and they're the ones managing depression, anxiety, and schizophrenia, and all that stuff is like sitting in their thing, unless they end up, you know, at psychiatry or something, which obviously they could refer to, but it's often management. When you think about that, and you think about like musculoskeletal and sports physicals, then you go off and think about internal medicine, like it's a huge breadth of information space.
Very intense, but you know, I think every physical therapy should at least take an ounce of what they know, dive into it, especially the stuff that affects movement the most, you know, or fitness the most, or you know, growth, adaptation to stress, which is kind of what we do. Like, we're the stressors of the system. We stress people, and we're hoping they adapt, and they can adapt if their blood looks a certain way. So, I mean, I love this move toward primary care. I think every PT should have taken that little bitty class they call differential diagnosis in grad school and explode on it. And to me, that might mean you read a lot from Peter Attia. You might listen to the Human Lab and get a little schooled on some peptides, which are growing in the United States. You know, I think we need to get better on that front. And I do think that chiropractors on the Instagram space have really been very powerful in this message. They've really taken hold of the idea of supplements and vitamins and looking at deeper aspects of health on a primary care level. I think chiros have done a great job at owning that over the past 2 decades. I think PTs should learn from that. We should get deeper into primary care.
Yeah, we have to have a better understanding of like overall health, which we talk about here so much, and it's so critical.
Well, I also saw it's all the specialties. They're all 3 letters.
Yes, they are.
They're really good. That's 3 letters.
Well, so you did mention like that idea of differential diagnosis. So that's like one of the big things that the specialties do is this. Like the OCS, for example, is really big on differential diagnosis of musculoskeletal care. So I think there's some wins in these preparations and the study and such with it.
Here, let me ask you, just for fun, how many PTs do you think there are in the United States?
35,000.
Multiply that by almost 10.
Oh, really?
Yeah, about 250,000.
Oh, yeah.
Over there, I'm sorry, they're over 300. So over 300,000. Now compare that to family medicine, general practice physicians. More or less.
There's probably more GPs.
Less by half. 150,000 physicians.
That's it?
Now, if you add in pediatrics, that's another 100,000. You add in internal medicine, you get another 200,000. So if we start blending,
Yeah.
there's blending, and all.
It doesn't really work though, Like if you think there's 350 million people in the country and everybody it's like seeing the dentist. Like you're supposed to have to go see the physician once a year. The math doesn't work out.
No,
it's impossible.
It's impossible to do
if it's that low.
It is. That's impossible. Yeah. So we're limited.
So yeah, the funnel system is completely corrupt if that's the case.
Yeah. It's a bit ugly. So what wins? The right healthcare.
Well, this is where the GP has fallen out of favor for I think a lot of people too. It's tough to get in. The information they get, they feel like they kind of already knew, or they could have got it online. So all of that's viable. I think it is a good chance to like ramp it up a bit. I think that if you had a musculoskeletal complaint going directly to a PT makes a ton of sense because they can be really, really detailed about it. And I mean, I feel like I'd love to see those people because I can save them so much time. I'm like, okay, hey, this is what's going on. It's definitely your knee. You definitely need to get it checked out. Let's go see an ortho. These are the guys I'd recommend. They're probably going to do these tests for you. Boom. But if we could like do that and actually order the test before they actually even went, and then, they went and saw the ortho in 2 weeks, they had all the tests done, ready to go.
Yeah.
It'd be way better for the patient. But the problem then you're back into the corruption situation. Yes. It would be more expensive for the insurance company to pay for all those tests.
Yes.
But it still would be cheaper for them to pay us versus paying a GP.
Yeah. Yeah.
That's amazing though from an access standpoint that they have 150,000 compared to our 3 something. Because I mean, we don't have to see people.
No.
People could go their whole life and never go to PT. You can't go your whole life and never see your GP.
No.
Like that just isn't. It's not a good idea.
Yeah. Yeah, and you could say, given what kills people, we should all start working on our joint mobility earlier.
Yeah,
and how much movement we do.
Yeah, you got to move.
There. So we got to move more for our heart, and we got to move more for our joints, and arthritis and our joint replacements and heart disease. Yeah,
the top 3 deaths still is like diabetes, obesity, heart disease are still the top 3 killers, right? So movement solves all of those problems. So yeah, I like the idea of us moving to primary care as well. I think it's an interesting concept, at least musculoskeletal primary care. I think there needs to be a filter on it for sure. But I think that I'd rather us see that than like an emergency medicine with like on the sideline in sports.
Yeah.
Honestly.
Yeah.
Like I just don't think that our training is at that level to be in that sports level. To get that kind of training, where there's athletic trainers that are going through school for 4 to 6 years to master that thing. And I think that they should. Yeah. They can take care of the sideline. They're much better at it than we are. They can do all that shit.
I went and saw my doctor not that long ago, and I asked for a blood test, and she said, "Why?" I said, "I'm just curious, flat out curious. That's why." And so she went over the data with me, and there's really nothing for her to add to my life. Unfortunately, she was very nice and sweet, but she's like, "Oh, all these look fine. You're good to go." I'm like, okay, cool, thanks. If an adult came and saw me, I've never had anyone leave with me not saying, hey, "By the way, I can help you a lot more than just today. I can give you so many things to improve on your knee health, your spine health, how your neck moves, how your shoulder moves. You can get a little stronger here." Like, because you're adult. If you're an adult and you're human, I can help you. That's where our capacity is, because we have yet to see a perfect mover. And when we find these little bugs, I can tell that you had an old injury when you were playing sports at age 18. I can tell that you sit at a desk, for your career right now. So we find these issues. So we should see people as a maintenance. Like, let me take a look at you. I'll see if we can prevent all these bad things that would happen in your 60s, 70s, and 80s that you don't need to suffer from if you just did a little bit of homework here. So I wish we saw more people just as a screen, just as a little look over. See if you can touch toes. See if your heel gets to your butt. See if you can rotate all the way.
I have to tell this story in this segment. I don't mean this to be negative at all towards GPs. It's just an example. I got a chance to shadow when I was a student. I got a chance to shadow when the guy, my PT set it up for me to go and shadow with his GP. So I was in his office for like 3 or 4 hours. We did the whole morning together. It was amazing. I learned so much from that. It was unbelievable. It was interesting. He was great. The doc would talk to me a little bit before we go into the room. He's like, "All right, this guy's a little bit anxious, so he might not communicate super well." Meaning that he had an anxiety disorder. And I'd never seen anything like this. Like, this person was literally like shaking like a leaf, and couldn't get words out. And I was like, a little bit anxious. I've never seen a person in that state before. That was incredible to see, you know. And then watch him like manage. He was exceptionally good at that. It was really cool. But this is where the problem is of this amount of spectrum that they have to work from. Because then we had another patient that day. This is like a 22-year-old male who was a construction worker, right? And he had back pain, right? Here I'm standing next to the doctor, like on his hip, as a student, but like fully ready to go. Like, this is my guy. Like, I can run the screen, you know, let's do this. I can help you, you know, like he has the guy standing, he goes, where's the pain? The kid points to like his, you know, his hip and back of his hip, left back of his hip, and then his low back area. And, you know, he like bent over and picked up some like wood or something, some concrete, and he felt it pop. And like, he hasn't been able to stand up straight in like a week, you know, like pretty straightforward musculoskeletal spine pain, right? So the question to me was, all right, are we going to order an MRI today and like see what this is, see if it's something more serious or not? X-ray may or may not be indicated. It's not like he fractured something at his age, but you know, whatever, maybe we see like something historical. Anyways, the doc takes a look at him and he goes, all right, he goes, well, sit there and can you bend? He was in a sitting position. Like, can you bend over? And the kid was able to actually. He's like, yeah, I can bend. He'd bend pretty good. And he came back up and he's like, okay. He goes, oh, do it again. And then he took his fist and he pounded on his spine. He just...
A vibration test.
Yeah. Like just smacked him in the back.
See if it's fractured.
It's fantastic. I mean, I'm kind of like, I've been through a lot of training and I've never seen that test. You know? Like, I mean, I've been doing this for 20 years now and I've never seen that test except for this day. Yeah. He hit him in L5, hit him in L4, there's right after the change, it's like a whap. Just like punched him in the back. And he's like, does that hurt? And the kid's like, no. He's like, all right. He goes, well, you're fine. I'll just take some ibuprofen and you'll probably be good in like 6 weeks. And like, no PT referral. You know, no further imaging. You know, just like, yeah, you work it out. I'm like, bro, like, I'm standing right here. Like, you know the guy who sent me here, who's actually a PT. And like, we're like a mile down the street. Like, this is the lowest hanging fruit in the world. No referral to PT. You'll be okay. Amazing. I was like, what are we doing?
Amazing.
But not taking anything away from the guy. Like I said, they have so much to be able to do. But that musculoskeletal exam, compared to what we're taught and the depth at which we dive, I mean, it was just opposites. It was incredible.
Yeah. Well, I mean, I do still see that a lot, even though I'm sure you're talking about something 20 years ago. Right? I still see these kind of quick and dirty looks, and the idea that if it doesn't need surgery, you'll be fine. That couldn't further be from the truth.
Right.
Further. And there is absolutely no research or sound thought or first principle that justifies that opinion. And I can't help but think that it's an opinion based off of their own life. And since they couldn't fix their own back pain, they just think, it is what it is.
Yes.
You'll be fine because I'm fine and I don't do shit for my back.
Yeah.
And you'll be just as good as me. So I have a very twisted sense that this is a projection of their own bias.
Yes. Because the answer is not clear.
Because the answer is not clear.
Either way. You know?
That's right.
But we know that movement's the right choice, but it's... If they're not choosing to move, which is common and hard for them to move, you know, it's a tough job. So, I think that's a big deal to consider the person's bias. It's huge.
Yeah. Well, we all have a bias, and I think we should be, as aware and transparent about it as possible. I tell people flat out, I said, I'll tell you my problem is I'm overly hopeful because I think you can get through this.
Probably,
But then whenever I say,
faith in the body. Yeah.
Whenever I do have that faith, I said I'm a pretty hopeful person, and I don't like this situation. Like that should be like, oh God, let's get the fire truck.
This is an emergency. On another front, like I was a medical director for the USA track and field. We had this big. This was a big one. I think it was the national championships or the world championships. One of the two big ones, and we were working with the athletes and. In Sacramento here, it was like 103 degrees, and we're running the 800. So there were 800 and 800 relay. It's just like, basically you just run as fast as you can, and then you get 800 meters, and then you puke. So you kind of get to your lactate threshold, metabolic acidosis, and then you just vomit, right? So it's pretty wild when you're going all out at that kind of intensity. The run takes about 2 minutes to get around the track twice, maybe like a minute something else to get around the 800. So it's pretty spectacular race, pretty elite athletes. But we see people all the time have these metabolic acidosis situations, and sometimes it's really difficult for them to recover. If they have asthma or if the heat is there and it's hard to cool off. Maybe they traveled, maybe they're tired, many variables, right? The more elite the athlete, the easier they have it. But nonetheless, we always, when you're running an 8x800 relay, you've got 8 lanes going, or 4x800 relay. So you got 8 lanes going, and there's basically 4 people in each lane. And so every, let's say 2 minutes, a person basically falls down and dies, for every 2 minutes for 8 minutes. So it happens for 4 rounds. Jeez. So you've got 8, 16, 24, you have 32 athletes in one heat, and there's 4 of these heats. So you have 32 of them giving everything they've got, the fastest they've ever ran in their life. And then they just all are collapsing, and they go to the recovery tent. And then by the time you get the last crew off, the gun goes off with the next heat. There's like 8 of these, it's like, oh my God, it's unbelievable. So anyways, I had the doctor there, who was the GP, and he did just a absolutely phenomenal job on managing this crisis. So we managed it very well, like on a basic level. But when somebody's not able to recover or catch their breath, you start to get a little concerned. But you don't want to send them to the EMTs or to call 911 because, of course, it looks emergent. But you're watching this process where you're watching. In track, you see this all the time, and you're used to watching the body adapt. As long as it's adapting, you kind of let it continue, right? But if it's not adapting, then it's like you have to intervene. And then sometimes there's a space in between where it's like, okay, like the heart hasn't stopped, they're still breathing, so we don't really need 911. We need to help them cool off. We need to help them calm down. So do we do a cold plunge? Do we put ice packs on the groin, armpits? Do we get them water? Do we consider running an IV? Like some of these different things, right? Really, really interesting. But this guy was just absolutely phenomenal. He had been at Notre Dame in the past as a team physician there, and ran an ER as part of his training, which is not common that a GP gets to get time in the ER. But it was just phenomenal to watch. We had 2 or 3 athletes of that whole cohort of group that he had to manage, and a very we never did an IV, we never dunked anybody, and we managed all of them really, really without any of them going to the hospital or anything. And it was just really incredible to watch. That skill set where I was like, I have no idea what to do here. Other than I can identify it's a problem. I can identify we have a cardiovascular issue. But, other than talking to him and training him and fluid, but he was just really good on their fluid management and getting the information he needed and working with him it was really cool to watch without using any drugs. It was really spectacular.
Oh, that's really cool.
So, it just comes down once again to the spectrum of skill sets that these guys have. And I think there's a place for us to be in between there. Whether or not, to answer my buddy's question he sent me, whether or not we have a specialty certification for it, I don't respect our specialties very much in the APTA because I don't think that taking a test and paying $3,000 qualifies you. That doesn't do anything for me. But if you've had good mentorship, you've had good training, you've gone through a residency, doing a specific skill, like I just mentioned, the guy at Notre Dame who spent time in the ER, that skill set lasted him. My skill set lasted me by being as a GA and being with athletes and training athletes and being at Exos and working with pro athletes and pushing them to the limits to achieve the best in sport. That's lasted me my entire career. But I wouldn't go anywhere and say I learned geriatrics, but I'm not a geriatric specialist. Can I help them? Sure, but not to the same degree as somebody else who's actually been mentored in that space.
Sure.
Whether or not they passed the test on it, I really could give a shit.
Yeah, it almost seems like the specialty is really just about what type of cohort do you want to see the most of. I think I got licensed before a lot of these even existed. I think most of these have been created over the last 15 years. Maybe they had 3 of them. And I just, if I want to see athletes, I just started seeing more athletes. I didn't really need to find let me, get something special to say that. But I will say this. I had another fun story. I had a trusted family. I've treated every kid and the mom and the dad of this family. Super healthy family, fit, they're active. All the kids were athletes. Now they're grown up. But the dad in his early 50s, quite fit. He had this calf pain. So he notified me, hey, Russ, I think I strained my calf or did something, but I can't get it out. I've got a chronic pressure in my calf and I can't stretch it. And so I asked him to do a few things. And I quickly ruled out a musculoskeletal problem. I think that the point of what's the skill set of a PT, we should be able to rule in and rule out musculoskeletal things pretty efficiently. If it's on the periphery of our body, hopefully it's pretty like quick. If it's in the trunk, might be a little bit harder. But for him, it's a calf issue, but not a calf problem. So immediately I said, well, that sounds like a DPT. Go to the doctor. Went to the doctor. They said no DPT. All right, kicked back out to me. A week later, hey, I still got this calf problem. I said, it's not your calf. So then what happened? He started having back pain. Okay, so we got a calf issue and back pain. Are they related? So a little bit of quick analysis. His pain was not in his low back. It was in his mid back, and it wasn't associated with movement. So I could rotate him, flex him, extend him, and the pain wasn't going away. The point of me saying it like this is that it's easy for us to say, hey, if I can't recreate your problem with a mechanical issue, then it's most likely not mechanically related. So what's in the area of the trunk? Well, it's his lungs. And lo and behold, the third time going back to the doctor, further analysis showed that he had a DPT and pulmonary embolisms in his lungs. So the skill set of the PT, I think we should be very comfortable in a primary care space. We should be very comfortable with ruling in, ruling out musculoskeletal issues. And it's kind of easy from my end. Like if this is not something I can help you with the stretch and exercise modality, like, hey, refer on. I think we need a scan, we need MSK, you need X-ray, you need a blood test. And I think that I'm very hopeful that we're continuing to move into a realm of medicine where people can get blood tests like that. They don't have to wait in line. They can literally just, like I told you with my wife with Function Health, I think once you kind of get with an online system, you could probably get a blood test at any whim. Just go ahead and call. It's going to cost some money, but I think we're going to come down to this booming concierge medicine that used to only live in the functional medicine space. I think it's going to explode to more of the online digital space, where you do have these doctors that can answer, probably these AI doctors, but nonetheless, they're probably doctors that can answer quick things online, but get you scans, imaging, and tests actually quite quickly.
Yep.
So this is coming.
Yeah, that's the future. You guys have to know this. If you're not aware of this, you have to know that like medicine can be much, much faster than it is. And the reason it's slow is not because of your doctor. It's not because of the delay to get into the machine or do the test, most likely. It's the insurance company putting up walls and making it authorization requirements and delaying the process that takes so long. If you were, like you watch this on Sundays or any pro sport, if you get hurt, you can go from, injury to full diagnostics, everything you said, blood work, lab tests. They have to run a culture sometimes on certain blood, so it might take 48 hours. That's a chemistry process that you have to go through, a biology process you have to go through. But otherwise, they can do MSK ultrasound, they can do X-ray, they can do MRI, they can get those read, they can get those reports done. Then the docs can do all the full evaluation. They can make clear diagnoses, within hours, within 2 to 3 hours in most cases, unless they have to wait for that culture to run, obviously. And that's what you see. You see this in other countries. I got a guy who was in Korea. He was in South Korea and was in Seoul, and he was feeling sick. And so he went there, didn't speak Korean, but he had a translator with him. So they went to the doctor together. The translator worked. He was with them. It took him less than an hour. In just less than an hour, he met with the doctor, ordered blood work and the appropriate internal organ scans to see what's going on. And in less than an hour, he had diagnosis. He had the medication because the pharmacy was also on site, had the medication, and everything was done.
You mean the cost?
It was less than $150.
Jeez. That's amazing.
Yeah, and this isn't a place that we as a country would think doesn't probably have the greatest medical care.
Yeah.
It was in South Korea.
Well, going back to the problem
phenomenal.
I had with my patient who had the DPT, the problem was that I didn't fully, I forgot to tell part of the story, is he couldn't get to the doctor. He kept getting blocked to see the doctor. And I think that's the problem. So it's not so much of the skill of the doctor, it's the model of the insurance that creates the barriers for you to talk with the people that you should be talking to. And it's tough. It's I think that the success of medicine is really less about how good's your doctor. It's how good is your system to see the right person. Can you talk to the right person?
1,000%. That goes back to this idea too on these specialty things where you go through these trainings or education. Yeah, I had the privilege over the last 10 or 12 years to speak all over the country to I don't know, thousands of PTs, massage therapists, chiros, whatever, but thousands of PTs. And we talk about everything from like one of the courses I teach is on shoulder. One of the courses is on different modalities and stuff for a variety of musculoskeletal conditions. But specifically some of my shoulder stuff in my knee classes that I taught how to do evaluation processes and how to do progressive exercise and such. And one of the greatest feedbacks from the people who attended was, hey, this is great. It's awesome. Like it really helps my clarity of thinking and what direction to go with patients and with the people I see. But they say it'd be really hard for me to do this though in my practice. And I'm like, well, why? What's the problem? So it's either time, they don't have the time to do it. 2, they don't have the equipment. They don't have any weight in their practice. They might have a 2-pound dumbbell, maybe up to a 10-pound dumbbell, but they don't have a 25 or a 50 or whatever to properly load the tissue to progress them. And it's sad. It's not that there's a skill set acquisition problem, because we can teach them the skill set and the people can acquire it and the doctors can get better, the PTs can get better, but the system is actually dysfunctional where they're not able to apply the skill set and use it in the process they are.
Yeah.
So if I was to give any recommendations back to like the APTA on this idea of like, do we have specialty practices and specialty models and focus on that, I'd say let's work on business modeling.
Yes.
And let's teach, because if we set up better structures, then people can be successful.
That's the limiting factor. An academic focus finds more things to find value academically. The problem is if the community doesn't see that as a value, then it's kind of a fake thing. Like, hey, trust me, if you give me $10,000, you'll get these 3 letters and you'll be that much more valuable to the world. Like, okay, we'll prove it. The free market should prove that.
Yeah.
And I haven't seen any business models that say, hey, we only hire, geriatric specialists. I see plenty of geriatrics. I see plenty of pediatrics. I see a shit ton of sports. I don't have a damn specialty to it. Not to say everyone's got to be me, but the point is you can impact value without necessarily a specialization. But I am definitely a believer of higher academics. But that, the user, the student's in charge to seek out the best knowledge possible and then learn how to apply it.
Well, whether or not it's higher academics or just higher skill set acquisition, right? I mean, whether you get that from a school, I'm not sure the school is the best place to teach skill set acquisition. But get that skill acquisition, if it's a fellowship, if it's a residency, if it's a mentorship, whatever it is, just experience with other colleagues, you have to acquire the skill sets. There's no doubt about that. And then you have to seek an environment at which you can apply them.
Yeah.
Because you can have the greatest skills in the world, but if you don't have any weights to implement it, then it becomes tough.
Well, this goes back to the book called Range, released last year, I believe, 2024. A fairly new book I spoke about before, and it talks about how we actually should be looking for breadth, because breadth and knowledge gives you an ability to be creative far past any specialist. The specialists in this world, they're frankly not as smart because they cannot be creative when you only know one thing, one niche, one focused thing. It's amazing as a generalist, you borrow tricks and behaviors and ways of doing things in a completely different way, and you'll be innovative naturally only with breadth. The more focused you get, you basically throw creativity out the door. And that was heavily proven over and over again. There's only 2 realms where a specialist wins: chess and golf. That's about it. So whenever you look at life and you try and call out all the greats, if it's Tiger Woods or the Grandmaster champion in chess, throw it out, because that's the only type of game in the world that has really a fixed number of possibilities with outcomes. Everything else is fairly open. Anything can come and disturb a journey, a thought process. You can have a lot of curveballs. The more curveballs in a particular position, you need creativity. That's why when you look at pitchers, there's no one way of throwing a ball, nor is there one way of hitting a ball, because they find that being creative helps. They're finding pitchers like completely revolutionize. Hey, we thought this arm angle was the only way, but then this guy hits a different arm angle. Guess what? He's now throwing without any issues. So right when you think that there's an outlier that proves it. And if we have breadth of how we look at the human body, you start to be creative in your own space. And I know I was like getting on a little soapbox here, but like I'm not so sure we should be preaching specialists. I think it's actually kind of stupid. How many times I've actually learned about behavioral health from overweight patients, then I've applied that to sports because it's habit formation. Just like you could learn from the addict and the gambler to actually rewrite positive habit formation for young youth athletes. And if you've never worked with an addict, then you don't know that. But that's actually rewriting habit formation just in the reverse way. My point is, have breadth, and your learning is unstoppable. You go niche, you're actually getting worse as you go. Read the book Range, and you'll be convinced, just as I've been.
I got to ask you a question about chess. I don't know if you have the answer to this or not. Do you think that the skills of chess are like transferable? Like the skill being that you have to be able to see moves ahead. So do you think that someone, if they're a good chess player,
so I would say
also good at other like skills in life?
So after reading the book, the author cleverly formed, when there's like really only a fixed amount of strategies, the answer would be limited knowledge. Meaning chess might do something, teach you how to look up and think 3 moves ahead, but it doesn't teach you about black swan events, outliers that you would never foresee, because in chess you already know all the potential.
You know the potential moves.
Yeah. So
because you're living in a constrained environment.
It's a very fixed and constrained, as is golf. So the more constrained the environment, the learning is limited, and it's important to then use that limited lesson and then move on.
Yeah, I like that saying of like, you're playing checkers, but we're playing chess.
Yeah. Or the 3-way chess or the 4-way chess. The amount of possibilities is expanded. Obviously, like 4-way chess is just like a made-up game. I don't think that is a thing.
I don't know what you're talking about. I'm not a chess guy, though. But I know my son plays chess, and he was quite good at it, so I was hopeful that it would be transferable. So it sounds like there might be some hope.
Well, I think the idea of like single-playing chess, there's like, 5,000 possibilities. But if it was like 2-way or 3-way chess, like, I don't even know what that is. More possibilities. No. I think it has limited lessons.
Yeah.
Versus soccer. Soccer is completely fluid. There is no, this is how you play soccer.
Because anyone can give a different move.
Yes. You look at Brazil versus England, 2 polar cultures, 2 polar ways of playing soccer. Anyone can win. The Brazilians were dominant for a while, then the English were dominant for a while. Who knows? The point is, at that game that's completely and utterly fluid and dynamic, there's no one structure.
Yeah. I really like that. My son's coach, like in soccer, he was an Italian guy, and he would talk to them about, you want to solve the soccer problem. Solve the soccer problem. Here's the situation. Here's the layout. Here's the defensive strategy. Here's what you're doing on offense. Solve the problem. How are you going to beat this type of defense? And whatever. It was a good way to get the kids thinking. This is when they were like 4th, 5th, 6th grade, so it was pretty good. Mm-hmm. Because I think that's the thing. I mean, that's the thing. As a good clinician, you're always trying to figure out, okay, what are the potential reasons for this person having the problem, and then how do we think the body might adapt? I just saw a person this morning. It was great. She has a rotator cuff tear, MRI proven. It's a traumatic one. She was snowboarding and fell down, put her hand down. It has it's a 4 millimeter tear, but it's full thickness. But all she can't do is abduct, so abduction stuff. Other than that, she's in great shape, works out hard, fully fit, everything else. So the healing potential is quite high, right? She's 50. So healing potential is still quite high, but there is a full thickness tear. So it's like, what do we do about it? And, she's going to see the doctor today as well and to get his opinion on whether or not he's going to operate. She's like, I know the doc. I know he's going to tell me that he can operate. I said, well, he definitely is going to tell you he can. No doubt. Mm-hmm. But I don't think he's going to suggest to do so. Mm-hmm. I said, you have full range of motion. You don't have very much pain. You're just a little weak. With external rotation was fairly weak. A little internal rotation was weak. And then her abduction was limited, but if she rotated her hand, it was clean. Mm-hmm. I'm like, you're not a surgical candidate at the moment, in my opinion, but we'll see what the doc says. Obviously, he could fix it, but the question is, should he? Mm-hmm. And at this point, I don't think you're going to find a doc that would suggest, let's fix this. Let's give you at least a month, if not 2 months, of some runway and see if you can get it better, because we can make you a lot better than you are. And, surgery can make you a lot worse than you are. Mm-hmm. So, probably not worth the risk at the moment. Mm-hmm. But it was interesting, like when I talked to her more about it, I said, hey, here's the deal. You're feeling better. I'm gonna challenge the tissue directly. Like we're going to do some stuff that's going to be hard. And the goal of that is cause adaptation. So one of 2 things is going to happen. It's either going to get kind of pissed, or it's going to get a little bit pissed for a short period of time, and then it's going to adapt and be better for it at the end. I said, I'm looking to find the dosage that gets us the second of those 2 things. Mm-hmm. If the first thing happens, you either did a little bit too much or it's not ready. Mm-hmm. But on day 1, it's impossible for me to know that answer. So we're gonna give you a dosage here, and I want you to run with it and see what happens and pay attention.
Mm-hmm. Yeah, I as you talk, I think like to me, it's always been silly in physical therapy to say I'm a shoulder specialist, or I treat rotator cuff repairs. I always thought that was silly.
There's no reason to be.
There's no reason to be confined, limited. Yeah. And in fact,
plus it doesn't work that way.
It doesn't work. Yeah. And if you say, well, that's all I do is treat rotator cuff repairs, I think you're lesser qualified than you think. I don't think you're skilled in understanding how the neck is compensating for the shoulder issue, or the influences of the core musculature in your hip alignment with how the arm reaches. Or if you're a specialist, are you a post-op specialist or are you a conservative specialist? And so I think to zoom out on specialty, I'm kind of I don't like it.
Well, it's because all systems engage. Like what I was going to say about that example, if it's a shoulder specialist, the name alone creates a problem with our model, right? Mm-hmm. Because because it's a kinetic linking issue. If you have a shoulder pain problem, like she fell on her arm, so she doesn't have it. At the time, she didn't have a kinetic linking problem, but now she does. Because now it doesn't work very well. So now the whole chain's screwed up. So for me, I can make the shoulder better. That's easy if it responds. And then now it's like, okay, now can I get you to actually use your arm again in a functional way? Whether it, right away she's like, well, I work out she works out at Lifetime in the Alpha program. So she's like, I need to do overhead snatch and overhead press and this and that. Can I get back to doing that? And I'm like, well, that's not exactly wrong, but it's not the right timing. And so we just need a little more time to get this thing to heal, and let's get a little stronger. And once you can do this, then we'll do this. Then you can do that. So that's looking like it's like 3 to 6 weeks out. But let's see how you respond, and we'll kind of know for sure. You might respond fast, might respond slow, whatever. But that would be a problem. And then same thing would be true. Like you're right on these specialty things. Like I don't think you should be a cardiovascular specialist separate from a low back specialist or an orthopedic specialist. Because
they're tag team.
The back pain is mostly tied to cardiovascular health, and if you're unfit and you don't have aerobic conditioning, you're going to get fatigued faster, and your back is going to be shit.
And are you truly helping that person with heart disease getting back into doing some light cardio? And you say, let's go on the treadmill, and they say, well, I can't because my knee and my back hurt. Well, I guess you're on the recumbent bike then. Like, fine. I guess you'll live and die on the recumbent bike. So here, we're loading up your heart to 90 beats per minute or 100 beats per minute, but we're not actually helping you live any more effectively because you can't walk or stand.
It defies
what are we doing here?
Yeah, it defies your favorite study about grip strength tied to longevity.
Yes.
A hand specialist could test your grip strength, but they couldn't explain to you why it has impact on longevity. That's it. Whereas somebody who had a complete understanding of approach of how the body works and how these systems are engaging with each other, they can understand that. And they can also just as well say, hey, you can still have great longevity even if you don't have great grip strength.
Yes.
Because here's the reason why that study makes sense.
Right.
You still have to move, you have to exercise, and if your hand's cut off, no problem.
Yes.
There's other things you can do to get the same benefits as somebody would normally have that had good grip strength,
Yeah, I do think it's pretty funny. They're getting all the research of what's the best sports to play for longevity, and they're finding, ping pong, badminton, and tennis are way high up there. And it's kind of like, is it a causation? Is it a correlation? And they're trying to, tease that out. But, what we know intuitively is if you stay active, well, that helps. So golf is nice, but you're walking, and so it's like, it's nice to walk a little, but everyone uses the cart anyways. Whereas badminton and tennis, you're moving, and you can be quite old and still play those things. So that
which are people like pickleball. Where are you reading, by the way? Where do you get that from?
No, I stopped my Instagram, so now I'm not fed that stupid knowledge. I started hating Instagram, so I got rid of it. But now I find knowledge on, whatever.
Just you talking to the robots?
Whatever. I don't know.
Yeah. It's interesting. Badminton's great though too. It's like pickleball, like the hand-eye coordination, the technical, the balance. I mean, and there's a little bit of quick motion in there, which is good. I think people don't understand like how much moving quickly is correlated with like hypertrophy and like muscle strength.
Yeah.
Like we associate that with like a different variable, like that speed of contraction and it's stretch shortening cycle.
Yeah.
But there's an aspect.
It's quite vigorous.
Yeah, there's an aspect of that also builds strength. Because if you can't, like that's the one counter I'd say to all like if you got to have 95% of max load to get hypertrophy and stuff, or you can move really fast.
Yeah.
because that also generates. You see,
That
fast
gets it.
people have big muscles.
That's
right?
it. Yeah.
And they don't necessarily load themselves a lot. So it's interesting, and you hear it every day. Like I just had another person today say they were doing great. Shoulder was doing amazing. It's been getting great motion. Da 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 da. They were working with somebody else doing something, and he's like, and then man, he had to reach across his body real quick. And he's like, dude, my shoulder's like toast. Like, happened yesterday. It's been sore for like the last 24 hours, and I can't hardly lift my arm. He's like, nothing popped in there. It's just so sore. I'm like, moved quick once. I'm like, that's because you've been working on range. You're so weak that you don't have any strength in there, and it sets it off. So, but it's interesting balance. All right. Well, thank you guys for watching KIMEcast. If you guys have any comments, if you guys have some opinions on this, throw it in the comments if you will. Let's love to engage with you that way and talk with you about it. All right, you guys have a good day. We'll see you.